Well, why don't we go ahead and get started, everyone. Welcome. First item on the agenda is the approval of the agenda and the previous minutes. Has everyone had a chance to look at it? Have both of you had a chance to?
The ones that were on the portal, it said that, I thought it said Kennedy made a motion to do something, and I thought, well, but that, I figured that might have just been on the portal thing.
Well, let's look. If I recall,
It said Billy made a motion and
oh,
to
yeah.
do something.
Mhm.
That's the only thing I saw. But it's not on the printed one, is it?
It is, and I think it's because he joined us.
Oh, okay.
But he's not.
Yeah, because I didn't see him in attendance, so it's odd that
He
he.
joined us, he was here and he came early and he joined us.
Okay, all right.
So that's what happened.
Okay. Fine with me.
Okay, we have a motion. Is there a second? Okay, all in favor say aye. Aye. All right. Report of the chair, just one thing I want to mention is the meeting in Pinehurst in December. We need to, if you're planning on attending, we need to register early so we can get the discount. I think it's, the date is the 5th through the 7th. I believe that's right. There is something on the 4th if you want to go to that. I believe Brooklyn will register us, and we have to make our own hotel reservations. So,
Might be hard to get a hotel if you have
yeah,
already.
I think Pinehurst is already booked up, I believe.
There are hotels nearby,
So
but
you can, we can get you, Gary, in somewhere in Rockingham. How's that? That'd be-
That's fine, I like Rocky.
Okay, all right.
One of my favorite places
Me
to
too.
visit.
I'm just kidding.
Rockingham.
Well,
We call Pinehurst Moore County where I come from. You never tell anybody you're going to Pinehurst for a conference. Say, oh, we're going out Moore County.
Yep. Yes, that's county talk.
Sounds more conservative.
That's right.
Yeah.
All right, Brian?
Well, I guess the big news is waiver got approved yesterday. CMS approved the waiver. I think we've got some kind of information that'll be at the portal and in your packets. Also, Tracy got a hold of a summary of some of the items that were not approved. But there's nothing in that changes really anything. I mean, it's the simple answer. You know, and the state, of course, was confident enough to go ahead with the RFP process without the waiver being approved, which, you know, made people scratch their heads a little bit, but I guess that gamble, you know, paid off because the RFP deadline was last Friday, and there were 8 plans that submitted responses. So things are moving right along. It's as real as could be. We had, let's see, some other activities that we'll talk about, you know, in the board meeting, and some things we'll of course share with you in closed session. Very successful provider summit. You know, we had 2 plan representatives there and a panel like we had last year. And the bad news was that it just happened to be that the General Assembly went into session, yeah, like a day or an evening, or I don't even know how long they were all in session. Just coincided with the date of our provider summit. So we're going to have Josh Dobson was going to be there and Senator Tommy Tucker. So they weren't able to come, so we had to kind of jerry-rig things a little bit without them being there. But that was all fine. It was all fine. And, you know, other than that, it's the quiet before the storm. Quiet before the storm. Headed to be in Raleigh next week for a couple of days with DHHS. Been pretty good about Having, much more face-to-face meeting time with the secretary and her deputies and having an ongoing agenda to work on things. We did execute a contract finally with them. That's always, I guess, worth noting since it ends up being a tremendous amount of, there seems disconnect on things that get discussed and what gets put in there and a huge amount of back and forth. That's kind of what we're used to at this point. So, well, we'll see what happens with elections, right? The next thing on the horizon. I can't think of much else.
Anybody have any questions, Brian? All right. This time, we'll go into closed session pursuant to North Carolina General Statute 143-318-11A1 in order to prevent disclosure of competitive health care information that is privileged or confidential pursuant to North Carolina Statute 122C, 126.1, not considered a public record within the meaning of Chapter 132 of the general statutes, and to consult with attorneys pursuant to North Carolina General Statute 143-318-11A3. Is there a motion to go into closed session?
I'll make that motion.
Is there a second?
Second.
All in favor, say aye.
Aye.
Any opposed? Unanimous?
Yeah, what I got instead is a lot of sore muscles from playing soccer.
Seriously,
and around.
my prescription isn't that good. He doesn't really want to close the computer.
Well, I probably shouldn't have.
All right, Miss Katie, I'll get your things.
Are you running the meeting? Yes, sir. I did not remember.
Oh,
Hey, are you?
all right, there you go.
Good. So I didn't see this in there.
It is behind the executive.
Okay, okay.
Well, we're going to go ahead and fire this meeting up. This is the October meeting of the RCTC meeting. We're short of a quorum. We'll go ahead and proceed, and we just don't have the authority to make official votes on the meeting. I'm glad that the camera is behind me because my nose is going to drip from time to time, and I don't want that on record. Because I have a cold. Disgusting. I think that everybody who's here has been here previously. So there's no new faces, so we're going to skip introductions. And we'll go ahead to the approval of the agenda. Have the agenda circulated? Does anybody have any updates to that agenda? I'll probably bring up something at the end. I can do that for some reason. The minutes from the last meeting were circulated for review. Does anybody have any additions or corrections to the minutes as they were circulated? Okay, once again, we want to approve them. That's the last times. They looked like they were good where they were. So let's move ahead into the peace law report, Martin Sanders.
Okay. Since we met the last time, the measures that we have received from the state have changed. So you'll be seeing some new things, and you'll be seeing a new design. Kate has redesigned the report, so it looks a little bit different than what you're used to. But hopefully we'll still provide you with the information that you need. We just, I think Kate, was it the first week in October or the last week in September, we received the July data. So we're really far behind on data. So this is the July report, and we have not received any of the other ones. Now that I'm talking about it, they told us that they would send the new dashboard by the end of September, and I believe we received it on September the 30th. But it only included the July data.
How would this impact the fact that some of these are super measures and that there may be penalties involved, that we wouldn't have a chance to correct until ex post facto?
Right.
That's just tough.
That is correct. And we just received, I believe we just received the contract, the fully executed contract. I believe we just received it last night, so I have not reviewed it yet. But the good news is that for the superbid measures, they lowered the number of people that we're supposed to house this year. And they're reporting it a little bit differently. So we don't have any concerns that we'll be able to meet the full year, even though we're receiving data so far behind. We're keeping up with our own data. Okay. So the first measure there on slide 3 reflects the difference in the way that they are keeping the housing numbers down. You'll remember that used to, we were doing 6.58 a month, and now they're looking at the total number of people who are housed. So if the previous month we had 200 people housed, and the following month we housed 10 more people, but 5 people leave housing, then our number will be 205. And so the targets will be for the entire year for that total number of people actually in housing on that day, instead of dividing them out by 12.
You could be compliant for 11 months in a row. Well, you're out.
What is that day?
It is, like I said, I haven't seen the contract.
Oh, I see.
But I think it's through June 30th.
It would be like on June 30th?
On June 30th. So the net number of people that we have in that house and that, on that date, is the number that they will count for us.
Your graph is
So,
yeah, and I know the Windows has Excel.
but we are above where we need to be. We're at 101% through July only. For the next measure, Kate has designed it so that you can sort of see the red line there that we need to stay above. And you can see where we are at as compared to our fellow LME MCOs. So we're in pretty good shape compared to them, but the important number is that we're in good shape based on the expectations of the state. So a new measure that they have implemented is the housing retention rate. And so the goal is for it to be us to be at 95%. And through July, we were at almost 99%. So we're okay there. You can see again in slide 6 how we're doing as compared to others. And right now we are just slightly behind Cardinal. But leading all of the MCOs. Slide 7. You have the deficit here. You'll recall from last time that we were reporting the number of people that we were reporting to support employment, the total number, and then the number of folks who were in or at risk. They have taken the total number away from the dashboard, and so now we're just reporting on the in or at risk people. We received those numbers probably mid-September, and so we're a little bit behind on on that. Right now, we're doing 50%. Our number each month is 4, and in July, we just had 2 that fit that in-risk category.
So,
I'm not,
those are tiny numbers. I mean,
Yeah.
what do we, is 4 thought to be reasonable?
4 is reasonable, and it's less than what our expectations were last year.
Right.
So, you know, if we, and I don't know what we had, but if we had 6 in July, then we would be at 100%.
I'm still not sure what they're measuring. Can you just describe that again? What is this?
So there are, the criteria for the sport employment is that what they're really measuring us against are folks who are in or at risk of going into an adult care home or who are in a psychiatric hospital who have unstable housing. And so moving those folks into employment by using the sport employment service. And so we need 4 people every month to move into that service.
Just 4.
Just 4.
Wow. Yeah, I agree with Jack. I don't know what to make sense out of
Well, we're gonna try to get as many people as we can.
it. Yeah, I mean, if you look at such small numbers, there may be people who just, not people who are at risk.
Right. And there are people who are not at risk, that we're still serving those people, but it's just not a measure that we're getting measured against anymore.
Okay.
So you can see, and the numbers on slide 8 will show you what the other LME MCOs are doing. You know, so the requirement for Alliance is 7 people a month. Cardinal is 12. If you look at East Point Partners, theirs is 1.
And you basically have organizations in our community like ABCCM and the Rescue Mission and Lida Home. You got all kinds of agencies
Yeah.
serving a far greater number of people in this effort.
It's only the people that are in the IPSSE service that has met fidelity get to count toward those numbers.
Right.
So right now, I think we have 3 providers that meet fidelity. And so they're looking at the number of people that we're referring a month. That doesn't mean the total number of people that those providers are serving. So I don't recall which providers they are. I think that it's RHA. RHA is one of them. Just use that as an example and pretend that it is. But if RHA may be serving 60 people in sport employment, and we send them 5, and 2 people may count for this category. So it's not that people aren't getting served, it's
Right.
just this specific category.
And it's possible to do better than 100% here.
Yes.
I love it.
And that would be what we're trying to do. So the next measure that we have is the individual's documented in-reach contact, and that's the same as it was last year, last fiscal year. And we're at 100%. In July, so it's not a measure that anyone is having any difficulties with throughout the state at this point, but we're still leading the state in that area. Our housing status after 90 days is the same measure as last time. And again, we're at 100%, and the majority of the other LME MCOs are at 100% as well. The housing measure is the only super measure. Of course, we want to exceed it at every day. On slide 13, individuals who received a housing slot within 30 days, we're at 82.4% right now. This is almost the same measure as last year, but last year, I believe the target was 7 days. And they increased it to 30 days. so they're giving us a little more time. But also trying to cut down with, of LME's sort of trying to massage the numbers and waiting until someone has a signed lease before they actually put them in the database. Because a lot of people met those numbers last year. And so we're trying to cut down on that, but they extended the time period for 30 days. And if you think about it, if you decided today to go out and find an apartment somewhere, it's probably going to take you longer than 7 days. So, as a whole, the LMNCOs felt that this was a little more reasonable. You can see that we are the only one, though, that is above the cut line. And the next highest there is Sand Hills at 70%. On slide 15, the in-reach contacts that resulted in the transition decision, there's no target for this measure. It's pretty much the same one as last year. We are doing a little bit better than we did last year. If you recall back, usually last year we were hanging around 2%. So but for July, we're up around 4%. We'd like to get that higher, even though there's not a target for us. From last year, you might remember the qualitative life surveys, that has been removed from the dashboard, so they're no longer measuring us against that at this point. Of course, we have to keep up what we were doing last year to make sure that we're still meeting that, but they have taken it off the dashboard for our measurements. So that's it.
I think it's really good. And if you're optimistic that these numbers are continue to be doable, then there's always that argument about just because that's the state target, should we be satisfied with it? Right. Like you said,
Well, we
try
want to
do what we-
exceed.
Yeah.
We want to exceed even like if there's not a target, we want to make sure that we're doing the best that we can. Serving all the individuals that we possibly can.
Thank you. Next is our corporate performance measures.
I'll start us out here. In the table of contents, and if you look at slide 3, we've got the standards that we've pulled off the presentation just because they continue to meet or exceed the standards. I do update those every month, so you can see our average scores there on all of those measures. Still meeting or exceeding all of those. Then we have our super measures information here. And we're sort of in some transition, of course, with a little bit of that too, but our preventative care for innovations members, they're still working on the educational materials on that one that'll be going out to providers. The current measure only looks at a subset of innovation members, and the expectation is for this to expand to all innovations members. So they're working on expanding that out, but that hasn't happened just yet. And then the current QIA includes all innovation members. So that's the way that we're treating it internally to continue to meet both the goals. And you'll see the numbers that we've got there. So we've been performing pretty high on that one for quite some time.
So what is that subset? Who determines who's in the subset?
That's the state measure guidelines, the guidelines that they've set forth, and they're just trying, we're trying, and a lot of the NCOs are trying to broaden that one out a little bit instead of just that subset there.
So try to see what the state.
Right. But we've performed really solidly on that one all along, so.
One of the things I really liked about this report was that ink on this data is fucking dry. I love it. That's because it's internal data, right?
Well, we try to keep it moving, keep it fresh, yeah, best we can anyway.
Yeah, wonderful.
The members housed through TCLI, so again, that one is the old numbers there, because it's just now changing to the new numbers. So the annual benchmark increased at this point to 94, but it's sounding like that might be a slightly different number. So as far as these numbers, we had it set for 7.83 per month. Internally, the team is shooting for 10 members housed per month to meet and exceed any goals that there might be. That also helps to account for months when you might have a little bit more trouble. So if you can beat that each month, then when you have a slower month, it's not quite as difficult. And then the current QIA involves TCLI, and that's provider network housing, so our housing team that's part of the provider network department. So what that means is we've got a current quality improvement activity that they've just started working on really to help the housing team and the TCLI team coordinate better on places to live. So hopefully fill more slots that way. But they just started working on that one. Then our follow-up after discharge measure, which has always been the more difficult one. Data was run on 10/8. So there's been a change in the contract there. At the time the data was pulled, the contract was for 0 to 7 days. There's been a change that it's, at this point, 1 to 7 days from discharge, and there's a lot of conversation going on about that. It does substantially affect the numbers. So instead of it counting visits on the first day after, yeah, we've lost a day. Yeah. And so that will continue to affect the numbers. And they're still working on the Pure Bridger application that we're hoping will continue to help support these follow-up visits. And you'll see our data there. We're doing better, but we're having to do a lot of cleanup to make sure everything matches what the state has. And these were broken down, so there was the DMH measure and then the DHB, it's the new name. NC Medicaid, that keeps changing. So again, that was run 10/8. And same thing, they've got the 0 to 7, changed it to 1 to 7, and so it is starting to affect our numbers a bit, but we're continuing to focus on trying to make sure our data matches what the state has. And compliance log.
Okay, just a couple of updates. So for the CDW episode completion record, substance abuse, for the fourth quarter, we were at 99%. Due to some restructuring, the claims and reimbursement department has developed a new action plan to ensure maintain compliance with this report. So MIS has introduced a test run intended to catch any record gaps in advance of the report being sent for the respective quarter, and claims and reimbursement will be working with MIS to implement enhancements to their current 60-day report to improve the identification of record gaps on an ongoing basis.
I have a stupid question. CDW computer discount warehouse? I think I would.
Client data warehouse.
That's close.
We like our acronyms. So for the TBI report, we have actually met the deadline for submission for the last 3 submission periods. So this will actually be removed from the log going forward. Unless, of course, we fall below again, and then we'll add it right back on and come up with resolutions.
It sounds like there were extra allocated resources that accomplished that.
There were,
Process going forward or necessary?
my understanding MIS is more fully involved with ensuring that this report gets completed and goes out. Prior to, a lot of it had to do with restructuring and the person who had been responsible for it leaving, and so we've kind of ironed out those little bit of kinks. And so I think that really is just a staffing issue, and now that we've kind of given it a place to land and a department to be responsible for, it's been doing fine moving forward. And hopefully it continues to do so. CDW discharges, this is basically where they don't want to see an unknown in a field. We met it at 100% for the fourth quarter. Again, because of restructuring, we've kind of had to change how our approach is on it. The claims reimbursement has reassigned responsibility for determining a method to ensure this compliance measure, or to ensure compliance with this measure specifically. They will be working with MIS to determine the best system to ensure all mandatory fields are complete for enrollment information received. NC SNAP, we also met the standard for the fourth quarter at 100%. And basically, Vaya has significantly improved on this standard. Care coordinators conducting NC SNAPs are striving to maintain improved turnaround times to ensure continued compliance on it. Perception of care survey, I think we did a report out at the last time, but essentially, we didn't get all of our surveys submitted that we needed to. So we have identified some areas to improve that process on, to ensure that next year's survey is completed as it should be. Kate, you want to speak to any of that, since that falls under your purview?
Sure, yeah, and we have had some changes, and so with the new performance reporting department, we've taken over the management of the surveys. And so we see those strategies, that was what we put together. In the middle there, increasing the sample size, having a really set delivery schedule, and then a more structured plan to make sure that providers are getting what they need and that we're getting back from providers. So hopefully, just that some additional structure will help us to get those numbers back up.
It sounded like you were just increasing the percent of each provider that you were involved in the process.
Well, and yeah, we were using a sample size that was similar from the last few years, and it just looks like we're gonna need to increase that. There are a lot of providers that are having a little more trouble getting the numbers that we had asked for, so hopefully by having more providers and a lower number, that'll get more in.
For EQR, we just wrapped up our on-site review yesterday. Just to give a brief overview, we felt like it went very well, and probably one of the better reviews that we've had so far in regards to just collaboration and the interviews and working with the teams. So we feel good about it, and we're glad to have that done and over with finally. URAC, I've probably told you this already, but we did receive full accreditation for the next 3 years for the customer services module, utilization management module, and for the network module, which includes credentialing. NCQA, we are moving forward with. We've already kind of started developing plans. We have a consultant contract went out yesterday for signatures, so hoping to get her on board. First step for her will be to review documentation for us and give us a plan moving forward on how to get everything where it needs to be so that we can meet our timelines that we have set for.
Can you explain why there were 3 of these? I thought we were going to abandon one of the.
Well, URAC, we can't, we were new. So we have to be accredited. At this point in time, we were not in a position to obtain NCQA at the time that the URAC would have expired, which would have been this year.
Oh, okay, so this is going to take over URAC. And then the EQR?
We'll probably be dually accredited for some time, and yeah, there'll be an overlap.
And the EQR is?
That's separate, that's with the state, under our contracts with NC Medicaid and with the Department of Mental Health, we have a requirement to have them come in and do an external quality review every year. So that won't go away as far as I know.
Who requires that we have either URAC or is?
Both are DMA.
Both
NC
contracts.
Medicaid and DMA.
So there's
Contract.
EQR and another agency?
Well,
Or do they look at different?
NC Medicaid requires the external quality review as part of their CMS contract. But NC Medicaid has a contractor that comes in and does that for us. So that we don't really have an option of that at all. We do have an option about accreditation.
We had a choice, but it looks like it's moving towards NCQA looking forward.
Right.
But the two accreditation agencies don't really do the same thing, so there are some areas that we may want to continue to have both of them, just so we're more fully covered with what it is that we do.
An example of that really would be the call center. There is, I don't feel like, NCQA is very quality driven, which is wonderful, but I don't think they're as clinically driven. So for example, with the call center, they really don't have but maybe 2 standards for the call center. So if I were to make a recommendation, it would be to at least maintain the URAC accreditation for the call center so that we have these standards and best practices that we're staying in alignment with.
It's almost like saying that without somebody watching over us, that we're not smart enough to set up our own standards to monitor.
Well, and I think it makes us valuable also.
You know, after so many years of dual commission, the hospital at great expense and hours, and not contributing anything that I can tell us. I'm just poisoned by the subject, but I think that these agencies, they do cause a lot of man hours.
They do.
Yeah. And, if they're necessary, I'll shut up. But if we're doing it just so that we have some guidance in that area, because we don't trust our own ability to monitor what we do, I don't like that.
We do have to be accredited.
Currently, we are required to have it. Like I said, we're not in a position to jump straight into NCQA. We just weren't. Which is what we're doing now while we've hired a consultant. But there will be an overlap, and there may be a decision at this point. I'm not making that decision. But I would recommend us to have some sort of guidelines in place. And primarily because I also think that makes us a little bit more valuable when we're dealing with other people outside of our organization who may be either URAC or NCQA accredited. So there's benefits to both. There's benefits to dropping it, which is financial. There's also benefits to keeping it, which could be financial.
For, Henry, do you want to speak a little bit about providers and other agencies that we use, if they're NCQA accredited, what that means,
Well,
and using our efforts?
Yeah, from a delegation perspective, there's delegation requirements. And if we're working with another organization that has the same type of accreditation, say either they're delegating things to us or we're delegating functions to them, it eliminates a lot of the work that has to be done, the oversight that you have to do between the 2 organizations, because the expectation is you're both following the exact same standards. So that does reduce a lot of man hours when we're trying to manage those delegation agreements. And so that's why there could be a benefit really to having both, so that we could work with organizations who had either or. And be in a position to do that to where there wouldn't be as much oversight and much man hours going into trying to maintain a lot of this delegation requirement stuff. For example, like annual report outs, reviewing policies and procedures, having to do pre-assessments, having to do like monthly reviews. I mean, there's a lot of work that goes in, especially when they are not accredited with our same accredited body.
Right.
And
Thank you.
I understand your JCO experience. The other benefit that I see as the business integrity person is that sometimes in organizations you become complacent and you think, well, yeah, I'm doing that. But when you have fresh eyes coming in to look at stuff, even though it's uncomfortable for us sometimes to have those reviews, it may give us some insight into ourselves that we're not seeing because we're too close to it. And so they can offer some recommendations. Sometimes we're free to choose if we follow those recommendations or not. And it just gives us that outside perspective to make sure that we just don't, that we're doing what we need to do, we just don't get complacent about things.
But the bottom line is they're just trying to perpetuate their own perfection. Okay.
I will say our reviews have always been, with URAC at least, very positive, very collaborative. They don't make me anxious. They may point out something, but it doesn't feel like they're coming in to ding us. I mean, it feels like they're coming in to be collaborative and to improve us. So my experience so far has been very positive.
There's nothing quite comparable to JCO and CMS.
Thank you, I'm sorry.
So just moving to the next slide, internal audit updates. We have The first, it looks like we did a run POC was denied by RCT, but the second one we received was approved.
A day later.
Oh, no, it's in review. Huh?
A day later.
Actually, it was denied on October 8th. We received it on October 18th, and we're reviewing that for approval. And if it doesn't get approved, then we would move that up to our regulatory compliance committee for review. The second one, they did submit a second POC, and we did approve that, so a 60-day implementation review will occur approximately from October 9th, so 60 days from that date.
So these are different.
There's two. There was one for allocation.
Oh, I understand. I thought it was like the same thing came back a day later. Like, that's very,
Yeah, one was mostly around the registry of unmet needs, and then the other one has to do with the innovation waiver allocation.
Okay.
So they're similar, but they're different. And we looked at different items for each.
And as a result of that audit, we made some changes, and Carla has taken that function under her wing. So we think that will be an improvement organizationally.
And so internal audit updates, we have completed the housing audit tool, and we'll be conducting that audit coming up in the next couple of weeks. And then we also will end up doing a claims and encounters one, which we've already started looking into, a special investigations and contract performance one, and one around our health populations and care coordination area.
And before Kate continues on, I just wanted to talk a little bit about what might be perceived as a discrepancy in the TCLI report. She has 19.4 on this. Toward the end of September, there was a flurry of activity about what our requirements would be, and we would go to one meeting, and they would say, this is going to be your number, and we would go to another meeting, this is going to be your number. We'll get an email, and this is your number. This was the 94 that she's reporting is the last number that we received when they were going to go with the same way that they were doing it last year, a certain number per month, which was still less than what we had last year, I believe. But at the end of the day, what they decided to report on was the net number. So our net number is 61.
that was actually an increase. It was like 6.83, went up to 7.96. Yeah, but thank you, because I was confused, because you told us that was deprecated.
But the actual number is a net number, so it's 61. So again, if we move 100 people out or into housing and 40 move out, we're not going to meet the number. But if we move 65 in and all 65 stay in, then we're meeting that net number.
Just kind of staying with that, like if someone dies, that counts against us. So there's some standards that.
Yeah, more even to the point, what we're frustrated with is if someone gets better, if someone becomes stable and gets a job and no longer needs wraparound services and supports, or if they find a life partner and move in with that person, they don't count and they get deducted from the total. So all of the MCOs are very frustrated because it feels like the message we're getting from the department is help them get better, but not
Too much.
Not too much. So,
But in the next report, we will reflect the changes that we received, like I said, at the end of September.
oh yes, yes we did. I can talk about that at the end if we have time. I can tell you all about our contract negotiations over the last 3 months. It's been frustrating. Most of this TCLI number has mostly been discussed at a monthly meeting that's held. It's called the QMDF, it's Quality Management Directors Forum, and all of the QM directors from the NCOs and the quality management folks from the Division of Mental Health and Division of Health Benefits participate in this call. And that's, all the MCOs have continuously and vehemently objected to how they're interpreting some of this, but that's where we are.
And these are DMH internal
Yes,
career,
yes.
they're not an outside consultant or a federal oversight or anything.
No, there is a lead over the TCLI program, Sam Hedrick. has been appointed. What is her title?
What stands
It's like
Is this different
CCLI,
from Jessica's was?
Yeah, it was with Jessica's, she's like special advisor on ADA or something like that. So there is a person in the secretary's office who is theoretically over the TCLI project as a whole. But they're not a consultant, they're an employee of the department.
So back to the core performance measures with the third chapter there. Slide 18 is just a little cheat sheet key there. On slide 19, the percent receiving Medicaid services. On that one, we have and you'll see I've added a trend line there in light blue. We have a very slight upward trend. The two in red have not matured yet. Those numbers will continue to come up over the next couple of months. And the trend line sort of stops before those. So you'll see that there's a slight upward trend on the 2-year on that one for Medicaid. On slide 20, the percent receiving non-Medicaid services, we've added the 2 lines there for when the fiscal year changes. At each fiscal year change, they change the denominator on that one. So it means that the numbers aren't as consistent as they look, but it's the best we can do to sort of graph them out. So on that one, again, you'll see there is still a very slight upward increase on that one as well.
That denominator in this year, did it go up or down?
Down a little bit, and it went down last year as well.
Right, because of certain Medicaid expansion.
They have a complex formula that they use to determine that number, and I can bring it sometime if you'd like to see it. I know. But yes, it did go down slightly for the year. Yeah. On the next slide, the mental health inpatient admissions, that number has been going up. And so there is a team that's actually working on the inpatient, the admission numbers and readmission numbers. So that one is trending up. Same thing for the readmissions, that is also trending upward. Again, that's why some energy is going into trying to address that and see what can be done. SUD inpatient admissions, Medicaid, slight increase, that's not a large increase on that one, but still an increase.
The last 4 points look good, but they're small numbers.
Right, it's a little harder to tell when it's moving in the right direction when we have those numbers. And the readmissions are much smaller numbers even still, so that upward trend is, it's not huge numbers, so it's hard to talk about the trend on that one too much. Mental health, inpatient admissions, non-Medicaid there, really flat on that trend right now. Those numbers always go down towards the end of the fiscal years as certain funding sources run out, so that's what flattens it out a bit. Dropped out, and that's why it dropped down there in June, the end of the fiscal year, and then came back up.
Was that actual admissions or just ones that might have paid for? I mean, why would that drop off?
If we're not able to fund as many individuals, and that funding does run out before the end of the fiscal year,
So
that's
these
what we
numbers
pay
are
for.
Are what we paid for,
Right.
not the actual.
That's right.
Right, so we're not influencing the actual admission rates by not paying.
Probably not.
I hope not.
Right.
Okay, that,
And it's usually just that 1 month that those numbers do that. Because you'll see it jumps up pretty high the next month. Hopefully to account for some of that. Readmissions is actually a downward trend there, but again, that's pretty small numbers, so not a major change there. SUD inpatient admissions is affected by that same funding issue, so you'll see the drop down there in June and then back up in July, but still on an overall downward trend on
And the readmissions are extremely small numbers on that. So the trend is downward, but again, you know, at the high it was 8. So down to 1, so.
It just seems like a really small number. 'Cause don't these include people that are admitted? And does this include like pregnant women admitted on substances? Or is this just for a pure mental health admission?
It's based on the primary diagnosis, I'm pretty sure.
Just on the primary?
Right. Right, so that probably wouldn't register with that.
Yeah. I mean, I've heard this many cases of endocarditis in the hospital.
And again, it's ones that we funded as well.
It just seems like
Well,
It
yeah,
must be the funding of last resort. They don't have that, you couldn't have provided this to.
Yeah, I mean, I'm sure it's a matter, I'm sure this funding is much smaller than it is for valve replacement.
well,
As an
if
example.
you look at a pregnant woman, if she was on Medicaid, is receiving a special class of Medicaid for pregnant women,
Right.
and so that would probably count
If we
differently.
haven't followed.
Right. Slide 29, the emergency department utilization. The reason I have 2 graphs there is to show the difference between the 1-year trend and the 2-year trend. That's the only reason that that's there. The ED numbers on the 2-year trend are slightly elevated from where we had been, but if you look at that 1-year trend, that's a much flatter number.
No, sorry, these are combined mental health and substance.
Right, I'm sorry, yeah. And yeah.
I think that was what all those letters were for.
Right, yeah, mental health, developmental disability, substance use disorder.
Yeah.
And so that was number of ED admits, the next one is percent of ED admits, which were readmissions within 30 days. Again, I showed both because on the 2-year, there is a slight increase on that, but in the last year, we've had a decrease on that. Slide 31 with the number of authorizations. We have a slight increase on the Medicaid, a slight decrease on the non-Medicaid on that. Very slight.
Can you help me understand, like, I'm going back to graph number 29.
Sure.
So the hospitals, and I sit on the board with all the hospital CEOs of just the 18 counties. They're talking about how many beds, overflowing beds, mental health disorders, how they're emergency. I mean, we've had times when people have been out in halls and people admitted. So that over 22 counties, that this would average, per month, about 20 per month, less than 1 per day. Where's the discrepancy?
So remember, this is Medicaid funding.
Right.
Yeah, most of the ED boarding crisis is in individuals who are not eligible for Medicaid. That's, and Brian talks about this a lot, but that's one of the primary challenges is that if you've got Medicaid, we can usually find a place for you because you've got a source of funding to pay for where you need to go. If you don't have Medicaid, if you are uninsured or underinsured, there are many fewer options. And that's one of the challenges that we face and why we try so hard to maximize those dollars, to leverage them together to reach the largest number of people.
Yeah, it seems like even still for Medicaid, that is a small number considering how many Medicaid.
I think that some kind of disability related to,
But again, I mean, this is all claims data, right? So this is,
Right.
we're basically looking at primary diagnosis, and just Medicaid.
and they can come back after their admission and be certified for Medicaid after discharge.
Yes.
See, that's why our numbers are low.
Yes, they can get retroactive Medicaid eligibility, yes.
Ultimately, the goal too is to keep them from having to go to the ED. So there are so many other ways to get the services that they need, and the ED isn't, as you know, always the best choice, so.
Yeah, I mean, I'm just thinking, just from a public health standpoint, is how we still need an accurate measure of the total impact of mental health disorders and IDD and substance abuse in the entire community, so we know, are we changing the needle? I mean, this is,
Well, we have an internal QIP specific to that. So I could certainly, we could have, I think that's a joint QIP with Dr. Martin, Rhonda, and Christina working on. So we could certainly have them put together a more comprehensive package of data that's specific to that question, if you want.
well, I'm not wearing my Vaya hat now, I'm wearing,
Sure.
you know, we have a new school of public health, and we have a psychiatry residency, and we have more ability. I'm thinking for 18 counties, not all of your counties, but 18 counties, but I'm just thinking, so if we're trying to be, we constantly lack good data to be able to say, where do we put our efforts? We use things like Robert Wood Johnson data, and
You know,
we
one
use
of-
other sources, but the hospital, you know, acute crises in data, that's the kind of stuff that we have that we use.
We have had a pilot agreement with the North Carolina, it's now Healthcare Association, the Hospital Association, to have immediate access to their admission, discharge, and transfer feed. We've had this pilot agreement. I know that Robert has presented some outcomes on how that pilot data was used, and they seem to be interested in making it a permanent agreement. So we have had, for a small number of counties, one hospital, Mission, a pilot agreement where we have been getting real-time ADT feed. And our goal was to demonstrate how we could use that data to affect outcomes. So definitely, I am not the expert on that, but I do know that that's happening because I did the agreement for it. So
Yeah.
I can work with Robert if you want some of that information, because that's where we think the most promising effort is we need real-time data. We need to know who's in the hospital today so that we can get them out of the emergency department. It doesn't help us to know 2 weeks from now that there were people in the emergency department 2 weeks ago.
And it doesn't, there's no meaningful way at this point for us to measure any large-scale interventions.
Yeah, but Robert, and he'll be here tonight, but he can answer any questions you might want to know about the ADT feed you'll be getting.
Great.
Slide 32 is the claims information. We do have a slight increase in Medicaid claims there over the last year, and pretty flat there on the non-Medicaid side. We've got the MCO comparisons after that, and this is the August information here. Our call time there, average speed to answer calls went up for the month of, or it was at 9 seconds, is above the other MCOs for the month of August. But our abandonment rate went down to below the state average on that one. And well below several of the other MCOs.
Excuse me, how's this, is this secretary?
Yes, I pull it, we have a system called Shortel and Bright Metrics, and I pull it from that.
Percent of enrollees receiving Medicaid services there for the comparison. For the month, we were the second highest for August. I've added an average on the bottom on the chart there, so that you can see for that last 13-month period where the averages are. And overall average during that period, we still have the highest rate for that across all the MCOs. They're right behind us, but still the highest. Percent of non-Medicaid, that number, we were second highest again for the month, but again, we're substantially higher overall average on that one for those services. The rate, two rate slides compare very similarly to the two that we just saw. So our rate, again, we were second behind Alliance for the month. Still have the highest rate across the MCOs for Medicaid, and then for non-Medicaid, it's the same thing, substantially higher overall, but we're second for the month of August. Our admissions numbers, as we talked about, are a little bit elevated. So we did have the highest admission number for August. And we do have the highest admission rate on average. And so again, that's why there is a team that's working on those numbers internally. And then our readmits as percent of admits, we had the highest percentage for the month there as well. Overall average, we are not at the top, but we are second on that one. The SUD admissions, not quite at the highest, but we were second on that one for August for Medicaid, and our overall, we are second on that one as well, behind Sand Hills. And then for the readmits as percent of admits on SUD, the numbers didn't get printed there, sorry, but we were at 14% for the month, tied with Alliance at that rate, but we were third overall. Rate of mental health admissions, non-Medicaid, we were at 1.26%, or 1.26, which did not put us at the top. And then our overall average, again, we are not the highest, we are several down from that. Readmits as percent of admits for mental health, non-Medicaid. We were pretty low in the pack there for the month, and but we do have the highest average on that one right now overall. SUD admissions, non-Medicaid, not the highest for the month again, and not the highest, so we're in the middle of the pack for the overall average on that. Readmits as percent of admits for SUD, pretty low rate there for the month of August, quite low. Not quite at the bottom, but pretty close. Overall, not the highest, but overall, that's one of the ones that we're working on. Our ED numbers there in comparison to everyone else, we did have the highest number for the month of August. On the rate of ED admits, we do also have the second highest average in the state. And then the ED admits as percent of total admits, about the middle of the pack there on that one for the month, and similar, a little bit higher for our overall average. Percent of Medicaid authorization requests denied, pretty low on that one, well below East Point Partners, and then our overall average is pretty low as well. The rate of Medicaid consumer authorization appeals per 1,000 persons, we are, for the month, definitely not at the top there. There's a couple people ahead of us. And pretty low overall on the average across the state. Medicaid consumer authorization appeals as percent of denials, second highest for the month. We do have a pretty high overall rate there at the moment, for the highest. Percent of non-Medicaid authorization requests denied. Obviously, a lot of us are in second place there at 1%. And we're in the middle of the pack there for the overall. Rate of non-Medicaid consumer authorization appeals per 1,000 for the month was a 0. So again, tied with a bunch of folks there for 0. And about the middle of the pack for the state average. Non-Medicaid consumer authorization appeals as percent of denied authorizations, again, 0 for the month. We do have an overall high rate, but that's because we had several months there when it had shot up. But they're small numbers, so. Our average number of days for processing Medicaid claims from receipt to payment, we did have the highest for the month by a couple of points there. And we are pretty high in the pack for the overall state average, but all still pretty close. Average number of days for processing non-Medicaid, again, we were at the top for the month at 6.9, and then not quite at the top for the state average. Non-Medicaid percent of claims dollar value denied by date of service, that's a heck of a title word. We were at 2% for the month, which puts us right in the middle with a few others. We do have a 5.8% of one of the higher averages, but I think there's been some corrections that they're working on with some of those numbers to get that straightened out. And then with our grievances and complaints there, for the month of August, we were at 32, so not the highest rate. We were 2.26 behind Alliance, and our overall rate on average is the highest, or second highest for the Medicaid there. And then the rate of non-Medicaid complaints, we were below the state average at 0.91, and our overall, though we do have the highest rate. Are there any questions I can answer? It's a lot of
Does Medicaid give a Medicaid? Does it provide you with comparison data, total spend between each of the NCOs?
Not to my knowledge.
Or the percents spent per NCO?
No, and we don't get the capitation information for other MCOs, so we don't know what their I mean, it's public record.
Yeah, I'm assuming.
We could request it, we could find out.
Well, what I'm thinking about is when you
But the
look,
state does not issue any sort of summary report that compares MCOs in terms of capitation and spending.
I mean, I'm looking at these utilization rates, for example, for hospitalizations, and one of the questions I wonder is that, if you have a big variation, even in a month, of hospitalization rates or ED visit rates, that's a lot of cost savings for the LD. And is that because the population is healthier and taking better care of it because of the LD, or is it part factors external to the LD? Certainly, it's probably mostly the latter.
We tend to think so, yes, but those are all good questions. You guys are gonna run out of time if you don't get through the rest of the reports.
Just gives a little time for questions that we can be thinking about. That's all.
Let's go ahead with the access to
All right, I have 2 quarters in here, so I have third quarter, which is January through March. And we met all of our combined standards, and so just brag a little bit about that. We, for our emergent, the state standard's 97, and the combined rate was 98. For urgent, which is seen in 2 days, is 82, and we did 88. And then for routine, which is our most difficult one a lot of times to meet, the standard of 75, we actually met it at 82%, which is amazing. And just kind of talk a little bit about the outlier there, that we did not hit our Medicaid emergent. And so I just wanted to explain that one a little bit. We connected a member to Mobile Crisis. The member wanted to wait until the next day to be seen. And they did follow through with that, but because that was with that, the 2 hours and 15 time frame, and that was the choice of the member, we were still dinged on that because it was not within time frame. So,
And that's for one more data point that you.
yes, yes,
So,
yeah,
that's very good.
thanks. So the fourth quarter, which is April through June, for the emergent, standard of 97, we made 98% for the combined. And I'll just go ahead and talk about the outlier with this one as we go. It was an emergent referral that we made to Mobile Crisis in Wilkes County. And they refused to respond to it and told them to go to the emergency department. So that was out of our control also, but it did knock us out for our non-Medicaid because of that. Vaya, our clinician that was handling the call, did file a complaint about that also. Then with our urgent, we had, of course, 82% was the state standard, and we met that all around at a 90% combined. And then our routine for the 75, we missed it by 1% at 74%. That was again our non-Medicaid, and the reason we had 44 prison discharges that quarter, and 36 of them did not attend their appointments. So it continues that the prison discharge continue to impact our non-Medicaid state members. But I will be happy to share that I just finished working on our one for this quarter, and we had a much larger, it was still like 44 didn't attend that were prison discharges, but actually 14 attended from the prisons this last quarter. I'm not sure what happened, but so hopefully we'll see what happens. I haven't got all of our results back yet, so.
I think that actually is about 10%, about 10% actually.
Yeah.
For anything.
Oh, yeah. Well, with that, yeah, I think that the hard part about it is, it's just kind of, I feel like it's a box that the social worker has to click, that they've made an appointment. Most of the time, they don't have a phone number, so we can't even follow up once they get out of prison to even remind them about their appointment or even try to reschedule it or anything. No, can't do anything.
Thank you. The grievance complaint.
So I want to start off with some news from our department. We have changed our name. We are no longer the grievance team. We're known as the resolution team because we do a little bit more than grievances. We handle complaints and complaints.
And it sounds a lot better, doesn't it?
And we got a lot of positive feedback
Yes.
from our external quality reviewer about that. They really liked that name change, so.
And I think that we had told you last time that the resolution team now reports to me.
With the resolution team, what?
Now reports to me. And the customer service team now reports to Mark.
So grievances per quarter, we're looking at quarters 3 and quarter 4. So we're looking at some trends going a little bit lower than where we were this past fiscal year. 118 on quarter 3, 88 on quarter 4. On page 2, we're looking at the types of grievances, and this is the perception when the grievant files the complaint or grievance. So you'll look allegations of abuse, neglect, exploitations. That's kind of been up, down, and that's typically what we do see. Access to services, same numbers. Quarter 4 is exact from quarter 2. We continue to monitor that for any kind of trends. We haven't identified any yet, but we still watch for that. On page 3, grievances, disability by type. you'll notice quarter four, for unknown disability, there was no unknown. We were able to find that out, so. Does not apply. Those are the ones that are not actually by or on behalf of a member and may not be tied to a service. Table 2 is same breakdown by disability, but it's rate per 1,000 served. So page 4, if you look at the top, those are the grievances against us. Those have trended up, and I think that we've talked about in this room quite a bit of times. The budget letters, the resource allocation letters, those are continuing to impact those numbers. Have some great news, grievances top 5 by service types. We've actually watched the grievances regarding ACT services go up. We've watched that over the past fiscal year. If you look, drastic decrease from 22 to 9. I went ahead and ran the numbers for this quarter one, and it looks like we're at 7. So hopefully continue to see that drop.
Has there been any change in anybody's ability, employee, client, et cetera, anybody's ability to file agreements or any obstructions to that? Are there other things influencing our rate besides the quality of performance?
So we've looked at that. We've introduced an online reporting ethics point where people can get to it from our website. But one thing we've seen a decrease in is rather than like Vaya staff when they file a grievance, rather than the concern coming to the grievance team and us sending it to investigation, it goes directly to investigation. So there's no stopgap there. So that does impact our numbers in a good way, because it still gets to where it needs to be. It just doesn't go through us first.
It doesn't imply that we're doing a better job, only that there's less work to do about the resolution.
We're trying to more accurately capture what are actually grievances and complaints filed by members in our health plan versus a care coordinator who may be out in the field and experiencing interaction with a provider that they feel is inappropriate, and so they report it, which they should do. We want to follow up on that, but those are different than things that are actually being reported by our health plan members. And so things that are being reported by our health plan members, we really want the resolution team to resolve. That's what they're trained to do. And things that are being reported internally by our staff are going directly to investigation through our contract performance team.
And is that a step function if they're not resolved by resolution when they go to?
I'm sorry, I couldn't hear your question.
If they're not resolved before the grievances that are not resolved, are they?
They resolve all grievances.
Investigation?
It doesn't necessarily mean that the grievant is satisfied with the resolution, but we attempt to resolve all grievances, and they all get a resolution letter outlining, if they're complaining about their provider, we will reach out to the provider to get information from the provider, do our best to resolve that. If they're complaining about Vaya Health, one of the things we've also done recently is really try to be a little more formal about those. So if a complaint is coming in about a Vaya Health staff member, those are now being reported to Human Resources. We have a new Human Resources Director who's fully staffed up. And so those are going to HR to be addressed in an appropriate HR way. So they will get a resolution letter. Again, does not mean that people are satisfied with the resolution, but there will be a resolution letter.
Is there a pattern of access to services? Does that mean appointments are not available, or transportation is not available, or is there
Could be both.
a pattern on that?
We haven't looked at any trends, so we looked at that by county, we looked at by provider, we looked at it by service type. And even though the numbers are high, there's not quite a trend around that yet. But we're going to still monitor that. If we do identify a trend, that's when we put that information all together, and we'll send that on to investigations for a formal review.
I think anecdotally, what we hear is that we get more complaints about transportation than we do about, transportation is a huge barrier in all of our counties, but especially in our rural counties.
Thank you.
And our last last page is where we break it down by unique individuals served, and this is by their county of eligibility. So since we're reporting both quarters 3 and quarter 4, those are together to look at a comparison. This is broken down by rate per 1,000 served. So if you look at it, it will look like Allegheny County. For example, quarters 3, quarters 4, 8.16. But when you're looking at 245 people served and 2 people file a grievance, as compared to Buncombe County, where we're looking at almost 6,000 people served and 40 file a grievance. Do they have any questions?
All right, some questions we answered. Let's move on then to the appeals.
Okay, so again, this is for quarters 3 and 4 of the fiscal year, January through June. And the service authorization request volume, after having a significant drop-off, is now starting to slightly rise. And that drop-off was due previously to services that used to require authorization, no longer requiring authorization. So the rise is,
Just hit decline.
it's distracting,
Like we miss it.
right?
So
So there's
we'll
just-
run up out of
Right, I think we have that. So there's just been a slight increase over the last 2 quarters, but again, it's still lower than it was and has been in the past. The spike in the denial rate in the last quarter of 2017 was attributed to the increases in PRTF denials and applied behavioral analysis services. There was a focus on PRTF services where they had longer lengths of stay, and so that impacted our denial rate for PRTF and those ABA services that did not meet the PSDT criteria. The rate of appeals for Medicaid clinical denials rose sharply with resource allocation. We have seen that come back down. It remains variable, but still relatively high.
If you don't mind, Catherine, I just want to interject here, I cannot emphasize this enough. Resource allocation is not something that Vaya Health created. Resource allocation is a model that the Department of Health and Human Services required us to implement. We're a government entity, and we don't have an opinion about whether or not that was an appropriate model. It was just the model that the department mandated that we implement, and it is the model that is contained in the 1915C waiver that was approved by CMS. So we get a lot of complaints and grievances about the model, and we've got a lot of appeals about the model, but I just need you all to know, this is not a VIA model, this is a DHHS model.
I'm very glad to do
Right. And there's been a lot of work done with care coordination and families, and many of those appeals that go to mediation, a lot of information is exchanged directly, and the process of resource allocation and the findings are discussed during those mediations, and oftentimes they are resolved. So, let's see, and then the percent of clinical denials resulting in reconsiderations, again, these trends, they rose sharply, but now they're on a downward trend. Of course, we're having fewer appeals, so with smaller numbers, the percentage tends to rise. But we haven't identified other trends other than the resource allocation, but we'll keep our eye on those and continue to report it. And if we see any anomalies like we did for that 1 quarter, we go back and compare proactively prior to the next quarter reporting. Any questions?
Let's see the quarterly numbers and try to analyze the time of the numbers.
Right. Well, we do that too, but that's not reported here.
Yeah, I mean,
Monthly dashboard reports, yeah, we do report those.
I don't have any numbers. The comments you made, the clerk, describe everything else.
Yes.
That's all that we have on our agenda. Don't you think
I can't give you an update of just where we are with our contracts. So the department did not get contracts to us at the end of the fiscal year, so they issued extensions, which is a little bit unusual for them. Typically, we will at least have a new contract on July 1, but this year we've got extensions through the end of September. Because of Hurricane Florence, those extensions were extended again. And we finalized all three of our contracts with the divisions at the department October 12th. So we have an amendment to our Medicaid contract. It's got a 20-page amendment. It's not huge, but it's not tiny either. We had a lot of back and forth with them. They had tried to put a lot of new requirements on us, which it's not that we were opposed to new requirements, but we're opposed to new requirements 3 months after the start of the fiscal year, when we've not had any warning about them, and we've already had our budgets approved. And so that's challenging. In the DMH contract, they wanted to cap UCR spending, which is non-unit cost reimbursement spending. And again, it's not that we're necessarily opposed, it's that we had already executed all the hundreds of contracts with the providers in our network, and would have had to start that process all over again. So we were successful in negotiating with the state. Hey, we can't have those kinds of changes in the middle of the fiscal year. If you want to make those kinds of changes, we really need to know about them a couple of months before the fiscal year so we can prepare for that, in our budgeting and our contracting. There are some new things in there. We have the new super measures for this fiscal year are in there. We did finalize our contract with the Division of State Operated Healthcare Facilities, which we're still a little frustrated with that. DSOF, they're a provider in our network, but they are exempt from almost every requirement that other providers in our network are held to, which we find frustrating, particularly, I don't know if any of you saw the recent article, I think it was in the McDowell News, but there was a fight club happening at J. Iverson Riddle Developmental Center, and at least 8 employees were terminated by DHHS within the last month or so. Again, this is a facility that's part of this Division of State Operated Healthcare Facilities that's in our network, but we're not allowed to monitor them the way we are private providers. So we're still a little frustrated with that. But in general, the contracting process went well. The state did make quite a few changes in response to some of our requests. But we do expect to see some of these new things that they're asking for come back in July. Okay. I can hear everybody outside.
What are you thinking? Why the heck, what do you think you're here for? Are you thinking we're back here? Is this something we must do? Did you miss coming?
We've got 5.
Did you miss coming to these meetings?
I knew enough.
What I think the issues with
But once it's approved by the board, it will be tonight, then I can get it. We've always got one of those. Things have changed, yes, they have. But nothing is
it's not
I dare you to go to the January or February board meeting and look and see if the documents presented maybe are on the back of
In fact, I was just at the funeral a couple of weeks ago. We had a development day school in town. It's, the kids, half of them are typical, and then there's half are, have different levels of
Let's
handicraft.
everybody find their seats.
I'll give us 15 hills.
Okay.
Jeff, you get a special award for being here.
We'll give you an extra audit report, how's that? Gift to keep on giving.
Maybe you could let him just go out of the way and walk that.
Shot himself. He shot himself again.
All right, welcome everyone. I think we have a forum. I'll do a roll call. Nancy Baker.
Here.
Ronnie Beal. Gary Blevins.
Here.
Rick Bunio.
Here.
Jack Kahn.
Here.
Howard Dove.
Here.
Jenny Duncan. Joyce Edwards.
Here, on the phone.
Okay. Jeff Heck.
Here.
Jim Holland.
Here.
Billy Kennedy. Michael Lavender. Pat McGinnis.
Here.
Michael Norris.
Here.
Morris Pittman. He was on the phone.
Here.
And Steve Smith, I believe he's given his proxy to our Dove. So we have a quorum. Welcome, everyone. All right, first item on the agenda is the review and approval of the agenda and the prior meeting minutes. Has everyone had a chance to look at the agenda and review the minutes from our last meeting? All right, Nancy made a motion. Is there a second?
Second.
Who seconded? Okay, Iris, okay. Any discussion? All in favor say aye. Aye. Any opposed? All right, it passes unanimously, okay. Public comment. I'll get it. Mary Short.
Hello. So, Mary Short, Katie Short from Alexander County, member of the public. So, let's see. There are a couple of things. First of all, on October 14th, I sent an email to the board clerk asking for notice of board meetings and asking for notice of county commissioner meetings. Gosh, I wonder when I'm going to get that. Hasn't come yet. And my reason for asking specifically for notice about the county commissioner advisory meetings is it doesn't even post any dates or times when they do meet. It doesn't even suggest that they're quarterly or annually or anything. So I sent an email October 14th to board.board@viahealth.com and have received exactly no response whatsoever. So the other thing I wanted to talk about was the innovations waiver has been posted for public comment, and I wanted to make sure that on the video for this meeting, anyone who's interested in making public comment be specifically aware that you can either email IDD listening sessions at dhhs.nc.gov or call 919-855-4968. And you can ask for a copy of the innovations waiver, either by email or by phone, but then you can also use that email or phone to make your public comment. So, I thought I would point out sort of a fun thing that I saw in the waiver that's been posted. It's 212 pages, so I think you should call and get a copy mailed to you. So here's the fun thing in the waiver that's been posted. Right up front on the first page of the waiver, there is a sentence that says, individuals living in their own homes and not with their families cannot receive community living and supports. The appropriate service is supported living or supported living periodic. And I thought, gosh, I went to a bunch of stakeholder meetings and that was never discussed at any of the stakeholder meetings I went to. And so I thought, oh, that must have been discussed at the stakeholder meetings that the LME-MCOs participated in, or maybe the service providers, but not the actual public or beneficiaries. So that sentence made me think, well, wait a minute, let's go read the service definition for community living and supports. Now remember, individuals living in their own homes and not with their families cannot receive community living and supports. The appropriate service is supported living or supported living periodic. So here's the first sentence for the service definition of community living and supports. Community living and supports is an individualized or group service that enables the person to live successfully in his or her own home. You're not laughing. Come on. Now these are people way above my pay grade who have put this document out for public comment. These are people who are paid with taxpayer dollars. These are people who are going to receive state pensions that are coming out of tax dollars that Katie pays. Seriously, you all need to make a public comment. And that's just, I read page 1 and immediately went to page 77. Seriously, this cannot be true. So, there's some talk that I hear about the resource allocation model and how that's DHHS. Well, you know, that resource allocation model is in the waiver that's out for public comment that the LME-MCOs all worked on. So they all had input into it. So it's not really a mandate from DHHS. They had input from all these stakeholders. Are you all getting the disconnect here? Well, maybe you're not. And finally, we had our fun little grievance and appeal report. And again, the rate of grievances per 1,000 served for the IDD community is, let's say 10%. But for the substance abuse, it's right at 2.5%. And for, for mental health, it's at 2.5%. For substance abuse, about 1%. So again, it's been at this 10% rate, these grievance rates for IDD forever. I have complained and complained, I've tried to make my public comment. You all need to try to figure out why the grievance problem never gets solved with your IDD consumers, and especially if we're going to go all the way to tailored plans, and IDD is going to be virtually your only consumers, but whatever. Oh, and I also then want to say, grievances, the resolution letter does not mean that it is satisfied, that the member is satisfied. It's just a resolution letter. And maybe you don't because you're not consumers or family members. Maybe you are, some of you are, I'm not sure. But there's no further way to appeal that. So sometimes people file when the same thing happens over and over again, they file another grievance, and they file another grievance, and they file another grievance, hoping that somebody is gonna figure out, why do we, so we get these same complaints and we send them a resolution letter. Don't they understand they're supposed to sit down and shut up? I mean, this is really, I mean, 10% per thousand. 10 per thousand. I mean, I just don't okay. Well, thanks for letting me vent.
Thank you. Jerry Ross?
Thank you, Mr. Chairman, members of the board. It's been a while since I've been here. My wife has been sick and she passed away since we last met at the board meeting, and there's been a handful of you that have sent your condolences, and I appreciate that and your support. It's been a long journey, but good strength of the Lord, we're moving on forward, and good people that's helped. So we appreciate everything y'all participated in during that time. There is an issue that I would like to bring up, and it's not a new issue. It's where I left off when I was at the last meeting, and that is public information. We are not getting notices for anything about it, about the meetings. We're not getting any information on the public website that we can download. If it's something that's somewhere that I don't know about, I'd like to be notified of that. And I had a public information request even before the last meeting that the attorneys knows about, and I still haven't got that request, and that was needs to be completed as well. I think the public, even though it might be just me and Mary coming, we've got one other here in the audience, hopefully she's a consumer as well or someone of that nature. I think you need to value us enough to put the public information out there. And if I'm wrong about what I'm saying today, I'd like to be notified of that. Coming to the board meeting and getting the packet isn't enough. We need to be able to be informed. So if you're going to have public comment, we ought to have the packet beforehand in order to be able to be educated on what we'd like to have input on, so that we can talk intelligently about it. So that's my comment today, and on that. The other piece I'd like to say is the hospitals. I've had 2 people recently that's been with their kids in the hospital and weeks in the emergency room, and couldn't get beds, couldn't get them took care of, and this is bad. The report today showed that. So there's nothing being done for the kids that is in this system when it comes to the hospital stays. So there's some work to be done. To me, I've always said it, and I still say it, attrition is what is happening with mental health. People are dying off since 2001. We are down to the place that mental health is nothing but a place where the vultures are landing. And there's nothing left on the table for the people that needs help. The insurance companies and people that are providers are making money off of these folks, and the care of the people is really sad. And I don't think that you can look at your numbers and tell me it's not. And it's not just about numbers, it's about the human beings. And I tell you, I see them daily, and I talk to them daily. And I just wish there's something that could be done about it. Thank you very much.
Thank you. Okay, our next item on the agenda is the audited financial statement presentation. Clifton Watson.
Thank you. Appreciate the opportunity to be here. I'm Jeremy Hicks. I'm a principal with CLA. Have with me Rachel Webster, who was the manager on the engagement here for Vaya. Before this meeting, we did have a chance to meet with the Finance Committee and went through the 2018 audit in a little more detail. You have received the same packet that we went through with the Finance Committee, but for purposes of the presentation today here for the board, we'll focus behind tabs A and B, which are kind of our required auditor communications, and then just a high level on the financial statements for the organization for the year ending June 30, 2018. If there are any questions as we're going through this information, please feel free to ask those as we're moving through. But behind tab A, again, which is our required communications, it is our responsibility as auditors to express an opinion on the financial statements. We plan to perform the audit to obtain reasonable assurance that the financials are free of material misstatement. As part of the procedures that we perform, we take a look at the internal controls of the organization. We use that along with the risk assessment we perform during the planning stages of our engagement to really kind of help us set up the testing that we do during our audit field work. We do utilize a risk-based approach, so in addition to some of the basic audit procedures, we do also focus our procedures around some of the areas of higher risk for the organization. An example of that is the liability for incurred but not reported claims, which is one of the larger liabilities for the organization and is an estimate that management records. So we spend quite a bit of time around that calculation as well. As far as the plan, scope, and timing of the audit proceeded as planned. Moving down the page, significant accounting policies, management is responsible for those policies, and those are outlined in note 1 to your financial statements. Based on the procedures that we perform, accounting policies in place do seem appropriate. There was one new accounting standard adopted in the current year around the organization's post-employment benefits. So with that accounting standard, there was an adjustment that was recorded as part of that process. This was an adjustment that was actuarially calculated, that we did some testing around. In addition to this adoption of this standard, there's also some additional disclosure included within your financials. So there's about 3 pages of additional disclosure added to the financials. This adoption is very similar to the adoption a couple of years ago around the standard related to the state employees pension plan, which required some adjustment and some additional disclosure there. This is just related to the OPEB plan for the organization. Outside of that adoption, no new accounting policies adopted, disclosures pretty consistent with what you saw in the prior years. As far as significant estimates go, we mentioned the most or the largest liability or estimate for the organization, the liability for incurred but not reported claims. Based on the testing that we performed, estimates used and reported by management appear reasonable. No sensitive disclosures. The disclosures included within the financial statements we consider to be neutral, consistent, and clear. On the next page, A3, just from an audit adjustment standpoint, we did have a couple of adjustments provided to us by management during the process. These were pretty small in nature, some cleanup items. Also had some audit adjustments that were recorded. Majority of these were primarily related to the pension plans that we just discussed, so the state employees plan and also the OPEB plan. Again, these entries related to the state and pension plan are provided by the state. The OPEB entries are provided by the actuaries, so we look at that calculation and help management with the reporting of those entries in the current year. No disagreements with management, no significant difficulties encountered in performing the audit. Management will provide us with a signed representation letter taking responsibility for the financial statements upon acceptance of the financials, and no other significant findings or issues to discuss. I'll turn it over to Rachel, and she'll kind of go through a high level for the financial statements.
We'll go behind tab B, the discussion of the draft financial statements. The first table you see there is a listing of all the individual statements that appear in the financial statement draft. There are a few new items this year. The other post-employment benefits has updated tables that are required as part of the adoption of GASB 75 that Jeremy mentioned. And then down towards the bottom of the list, there are 2 new statements required by CMS and DMA related to breaking out your statement of net position and your statement of revenues, expenses, and changes in net position between Medicaid and non-Medicaid. So there are tables in the back. This is done on the full accrual basis, so they in total match your statements at the front of the financials. But they wanted to start seeing what the net position related to Medicaid was versus non-Medicaid. Non-Medicaid would include
state and federal, local, county, HUD, everything that does not directly relate to Medicaid. And we did get help from Vaya staff in breaking out that information. You guys already give this information each month in the DMA reporting packet that is sent. This is just the first time it's been formalized in an audit, and that was something that was new this year. We did present an unmodified opinion on the financial statements, which is the highest level of assurance that may be achieved. You'll notice in the statement of net position ratios, unrestricted cash decreased again this year. In looking at the statement of revenues, expenditures, and changes in net position, total net revenues and total and operating expenditures were under budget. Your revenues did increase by about 17 million this year. There were some additional state and federal money, some new grants this year, and some additional single stream funding that really led to that increase there. And then your expenditures increased about 11.5 million, the majority of that in the contracted services line. So overall, expenditures exceeded revenues by approximately 8 million compared to a $13.5 million loss in 2017. On the next page, Vaya did administer 76 million of federal and state financial assistance during 2018, and again, you see an increase in the funds there. This is the funding that we do additional testing on related to compliance, related to single audit or yellow book testing. There were no material instances of noncompliance, no findings noted in compliance testing, and no material weaknesses in internal control over financial reporting. So overall, a very clean audit from our perspective, no issues that we noted during our testing. And always like to give appreciation to Amanda and her staff, Amanda Robinson and her staff, for their help during the audit. We make a lot of requests and they're always right there able to pull them for us.
From an internal control perspective too, obviously we don't issue an opinion on the internal controls of the organization, but as I mentioned in our required communications, it's a big piece of the testing that we do during our audit process. If anything rose to the level of a material weakness or significant deficiency, which would basically be a material misstatement of the financial statements, or potentially be a material misstatement without being detected due to a lack of controls in place, we're required to report that to governance. I'm happy to report there was no material weaknesses or significant deficiencies based on the internal control testing and also the substantive testing that we did during our audit process. So very clean from that standpoint. Again, we went in a little more detail with the Finance Committee, but I'd be glad to take any questions that the board might have related to the audit or our processes, and certainly appreciate the opportunity to work with the organization.
Do you do audits for any other colony agencies?
We do. We do 4 of the 7 in North Carolina. We do the audit for. We also work with MAHEC too.
Are there any other questions or comments? We need to make a motion to accept the audit. Okay. Is there a motion? There's no questions. Is there a motion to accept the audit as presented?
So moved.
We have a motion. Is there a second? Second. Have a second. Any more questions or comments? Hearing none, all in favor of the audit as presented, say aye. Aye. Any opposed? Aye. It's unanimous. Thank you. Thank you very much.
Thank you very much. We appreciate it.
The next item on the agenda is the conflict of interest disclosure. Calling Tracy Hayes, our General Counsel and CCO.
At this time during the board meeting, I would ask that any board members that have new potential or actual conflict of interest, if you have not already reported that, please do so. Nothing has been reported since the last board meeting.
Tracy, I was voted on the board, but I asked first, and I was I asked them to remove me.
The board
For first. So I did ask them to go through and remove me from the board.
And First is one of the providers in our network. Thank you, Nancy. Anything else? Thank you.
A couple items to bring up at this time. the Pinehurst Conference is December the 4th through December the 7th. You have information in your packet, and if you are thinking about going, you'll need to sign up soon. Let Brooklyn know so she can sign you up. Go and find a room at the resort. Now is probably impossible, but you'll need to get on board pretty soon with this. So again, it's very important that you want to attend. Thinking about it, that you will go ahead and sign up. So again, you have the information. If for some reason you don't, keep in touch with Brooklyn. She can get you that information. I attended the CFAC retreat earlier this month, and it was really appreciate being invited. Nancy, Pat.
Thank you for coming.
And very informative. A lot of good discussion there, and I'm sure we're going to talk some more about it later. You also have some information in your packet about vacancies, reappointments. Please look at that information. We need to make those appointments for reappointments at our next meeting, which will be November 29th. Is that right?
November 29th.
November 29th. So there's several. Does everybody have that information in their packet?
I don't think so. I think we just got it for you.
Okay.
So sorry about
If you
that.
don't, we'll get it to you.
But just in general, if y'all recall when the board was set up, we did it in staggered appointments. So basically every 3 years, there's a group of board members that are up for reappointment. And so there are a number of board members who are up for reappointment this year. Let's see, Dr. Heck is up for reappointment. Joyce Edwards is up for reappointment. Ira Dove is up for reappointment, again, because you had filled a slot that was vacated by Carolyn Coward and Pam Holcomb. Let's see, Michael Lavender is up for reappointment. Marsh Pittman is up for reappointment. And then we have several vacant slots, and so we really just needed to make sure the board was aware that there are some vacancies. So if you were thinking about wanting to fill some of those vacancies, you would need to let Rick know, so we can prepare a vote on that if necessary at either the November or the January board meetings.
Are any of those vacancies those designated seats?
The CFAC vacancy is a designated seat, so the substance use, an individual substance use lived experience is one of the vacancies. That was the slot that was refilled by Judy before she took a position with one of our providers in our network. The other vacancies, I believe, let's see, it's an at-large, and then we have had, if you will recall, for quite some time, what is known as the secretary appointment, which is a vacancy, and we've not had any DHHS secretary appoint anyone to our board. So, ever. So those are the vacancies. And then typically at the last board meeting of the year, you would also vote on officers and executive committee members. So we'll prepare all of that for the next board meeting, but we just wanted to make sure it was on your radar in advance.
We'll make sure you get an email with this information. All right, next item is report of our Chief Executive Officer, Brian.
And I also appreciate Nancy. It was impressive. I think I was there for probably 3/4 of it. It was nice to have Cody come.
Very.
Yes. He did a good job, and I'll say that you guys got great reviews. Let's just put it that way, okay? It isn't because, you just like had a nice retreat. I mean, it's the whole way that you folks do what you do and our relationship and all of that. Christina had quite a conversation with someone from the department at a very high rank and commented as such, so. We had our provider summit. We started this, I don't know, maybe we started this when I came, shortly after. It's like an annual meeting, so to speak, with our providers. And it started off, decent, and it's really grown over the years. And now, we have people come, actually from all over the state. I think we had 250, 300, 280 people this year. And had it at the Crest Center, which was a wonderful place to be in the middle of October especially. And had secretary speak there. We had representatives from United Healthcare and from American Heritage do presentations on standard plan and also be part of a panel. We almost had Dr. Heck next year. But it's really heartening to see this grow and become such a professional event, and we get pretty nice comments about it. Financial solvency. You said in Finance Committee that this is something that we'll probably talk about every month. I find an easy way to describe this. Very well intentioned to create some kind of rules around which our funding and our savings, our Medicaid savings, could be evaluated. Rather than it's really a free-for-all now with the General Assembly deciding to take money from us. They do it simply because it's there, and in their view it is reachable by the state, and I won't get into the argument about whether or not Medicaid savings are actually state funds and all of that. I think there's a lot of disagreement about that, but nevertheless their practice has been to simply take it or to manipulate the budget in such a way that they make reductions in state funding that we are required to fulfill. So it amounts to the same thing. And that's been the practice, for several years. We're down, what is it, $35 million ballpark?
Yeah, I mean, if you look at cash and investments, we're not including medical risk reserve, it's about $55 million today. And it's going down at a rate of about $3.5 million.
I'm just saying, over a period of time, how much state funding we've had to backfill. So anyway, the notion that someone should come up with some rules around how much money we should have. People have had that idea for years, and it's never gotten to the level of someone taking action on it. This past session they did. And it's very imperfect. It's a formula that Clark has reviewed in the Finance Committee. I think next month would be a good idea to really kind of detail some of that in the committee and show you how complex it is. But essentially, functionally, what it is going to do is to hold us at the lowest level of retained earnings that we can possibly be at. And I would even submit that no one that would run a business would organize their savings in the way that we're going to be required to. I really think that's a fair assessment of it. It keeps us really at the brink. So, the rules around how we are going to be required to spend money to get down into a particular range that they will find is acceptable is really important and very complicated, because there are certain elements of losses that drive the formula. Reinvestment funding is a big piece of it. And really, if you look at this, after a couple of years, or maybe 3 years, we won't be spending any money on anything, because it'll be all gone. There's no reason to believe that there would be any pickup, if you will, in rates. They continue to be compressed. So our ability to create savings will be eliminated, and all the money that we have saved will be eliminated. Now, this also comes at a time when we know we are going to have have additional needs as an organization, we're gonna have to become NCQA accredited. We're going to have to prepare to be successful bidders on tailored plan. We've spent a lot of energy and resource and financial commitment to care coordination and really building out that platform. So it isn't as if we aren't going to have things that are very important to the organization to spend money on. You're going to hear later today about a sort of a targeted, if you will, COLA or some salary increases that we're going to do. So you combine all of these features, and we also know that there's going to be significant risk next year on rates because of the large number of people that are coming out of our capitation. Okay? Going into standard plan. So it's likely that once the standard plans are up and running, we would only be getting paid for 10,000 people, let's say, maybe 12,000 people, as opposed to anywhere, at any given point in time, it's like 170,000 people, annualized, it's over 200,000 people. Clark, just for the heck of it, figured the factor of difference in our PMPM, which is like it's $165 now, it would have to be over $2,000. Do you think the department's going to hold us harmless for that period of time between standard plans and tailored plans going live? Now, once tailored plans start, our capitation will be accounted for by the additional medical expenses. Okay? So it'll be equalized by additional service expense. In this period in between, our fixed costs for administration aren't going to go down significantly. We're not going to be doing that much less, really, because the majority of those folks for which we receive a PMPM for, this is an insurance model, okay? Mike, your car insurance premium, you pay it whether you have an accident or not?
If you, if you
You do,
don't
don't you?
yeah.
Right, so essentially
Yeah.
you're paying for other people's expenses, right? Same thing for us. Except now, we're going to have a pool of individuals that are all going to be expensive because of the complexity of their needs. It really turns an insurance model into a, what would you call it, a high-risk pool, right?
Without funding.
Without funding. Right. So you see, we have the alignment of a lot of very, very worrisome financial features. Solvency, which is going to, ironically, make us spend money that we'll have to do in very, very intelligent, targeted ways to meet the requirements of reinvestment, which are significant, and there's a laundry list of what those categories are. It's not just kind of a wide open thing anymore. And then spending in a way that positively affects our solvency calculations. So it's a very complicated challenge for us to stay financially healthy. So if there's anything you'd like to add to that, Clark, he's going to be bright-eyed and bushy-tailed tomorrow morning, my mother would say, for a phone call as the state has submitted their report on the solvency legislation that the state has created. And we had a big meeting, it was up with the secretary and the deputies and the lead financial research guy from the General Assembly, and it was just I'd say a disaster, but you could just see how it's just full of poorly thought out, weakly calculated methodologies. So, now everybody's trying to scramble to make it a little more reasonable.
Are we we have a conference call tomorrow at 10 o'clock with some of the DHHS people, Roger Barnes and on the finance team, and Al Greco and a couple others of their team. We will be discussing these solvency calculations. The draft report that they sent out contained not only their calculation for us, but some of the recommendations that they're going to make to the legislature. We in turn made recommendations back to them, so we're all going to get together tomorrow and kind of digest all of these recommendations and hopefully come out with something that not only works for all of us, but that the legislature can accept as well. So it's a calculation that's in flux right now, but we hope to get to the end with something we can all work with.
All of your peers will be on this call.
All of my peers will be on this call, yes.
Bottom line is that all of our spending, whether it be related to just traditional budgeting versus more ad hoc things related to reinvestment, everything has to fit on this 4D chessboard of solvency. So, whoopee. Support for Trillium. We have some photos in the packet. We did our best to support Trillium. You know, their counties were just devastated by the hurricane. And you know, our members are some of the most vulnerable out there. Just a tremendous challenge to get people back on their feet. So we did kind of a drive, so to speak, and I think they put some pictures in your folder of us delivering. You know, we did everything from Amazon gift cards. We took a cash collection, and then other people donated food and other items, and it was nice to be able to, you know, so we delivered them in a truck, and they took some nice pictures. So it was nice to do our part. They're one of our partners in the coalition. It's certainly nice to support them with that endeavor. And you know, it's probably a lot of those areas never going to be the same. Very rough, very rough.
Will there be some, we know there'll be additional needs, will there be any additional support that will be in a position to provide?
Well, you know, at the time, we really jumped in, and I don't know if we did ever provide backup for their call center. Did we end up doing that, or no? I know they were ready to pull the trigger to do it at one point, where, you know, they just couldn't get people, couldn't get a hold of people, people had no electricity, you know, you fill in the blank. I mean, it was just a complete disaster. So we had a plan in place that if they were to call, we would have acted as their call center. And I don't think they ever pulled the trigger on that, to my knowledge.
Some of our providers participated. There was several calls that we were part of every week, and they were really in desperate need of clinicians. And even up to like 2 weeks ago, they were looking for 20 to 25 clinicians from this area to go spend 2 weeks in Eastern North Carolina for people who were still living in shelters, and to help those individual people, which is just heartbreaking to begin to recognize and accept that there was no community or home to go back to. And so they were really looking for people who could come and really stay a period of time. And we have truly had, we probably didn't have 25, but throughout this whole period of time, many of our providers, their staff, took time and volunteered, or took time off with no pay, and have gone to help. And we're very appreciative of that.
You know, a lot of folks were displaced as far west as Winston-Salem, because the shelters were all full in the east of Raleigh, so it's... Yep.
You know, one of the ladies killed being transported in Myrtle Beach was from North Carolina. We had quite a discussion about that, not on the last state telepathy back call, but on the one before that, and whether she had been referred by North Carolina to somewhere in South Carolina, or how that happened. We still don't know, but some of us are really concerned.
Okay. All right, at this time, we need to go into closed session
pursuant to North Carolina General Statute 143-318-11A1 in order to prevent the disclosure of competitive healthcare information as privileged and confidential pursuant to North Carolina General Statute 122C, 126.1, or not considered a public record within the meaning of Chapter 132 of the General Statutes, to consult with attorneys pursuant to North Carolina General Statute 143-318-11A3, or to consider the qualifications, competence, performance, character, fitness, or conditions of appointment of an individual public officer or employee pursuant to North Carolina General Statute 143-318.11A6. Is there a motion for?
So moved.
Okay, we have a motion. Is there a second?
Second.
All right, we have a motion and a second. All in favor of going into closed session, say aye.
Aye.
Any opposed?
Are you ready? We're gonna stand up. Are you ready? And up, up, and up. There you go. Good job.
This is the board I made copies of it, I just did.
Okay.
Okay, all right. Our next item is report to the Finance Committee and Chief Finance Officer, Mark Phillip.
Thank you, Rick. In your finance packet, we'll go through this very briefly. The first document one, is the balance sheet. We're currently about $56 million in cash. The three items that have increased or decreased significantly since the end of the year. Our cash has decreased about $3.4 million. Accounts payable has decreased about $6 million. And deferred revenue has gone up about $4.4 million. That's the single stream payment that was for the month of September that came in early, late in the month of August. So moving on to document number 2, which is the statement of cash flows. This, you can see that the cash decreased about $3.4 million. That's mostly related to the net loss from operations of $3.2 million. Moving on to document number 3, which is the current ratios. Looking at the total current ratio, the total current ratio is about 2.38, which is consistent with July and down a little bit from the previous 2 months. Looking at document number 4, which is the defensive interval, which is cash balances. The requirement is to have a 30-day cash balance. You can see the trend line has continued to go down on the cash for the reasons we discussed, inadequate rates and so forth. Moving on to document number 5, which is the income statement. It's not terribly useful information, only 2 months into the year, but we are behind the budget. We have lost about $2.1 million versus a budget of about $800,000, so we're running behind on the budget a little bit. That's mostly due to Medicaid. We're about $4.3 million unfavorable to the budget on Medicaid, and we're actually $3 million favorable on the non-Medicaid side. So there are a couple of things that are going to come on the stream in the month of October. They're not reflected in these financials. The Medicaid revenue was over-deducted related to some terminations by $2.2 million. So we will get that back in the month of November, but we'll be able to book it in the month of October. And we also received a letter yesterday for the return of single stream funds related to last fiscal year, which is $3.1 million. So we expect to have a $5.3 million increase in revenue that we don't normally see on a month-to-month basis in the month of October. So moving on to document number 6, which is the medical loss ratio. It does spike, but for a couple of reasons. Certainly, it generally moves up in July because we have gotten inadequate rate increases from the state starting in July, but we also have this over-deduction on revenue, which causes the ratio to go out of line. You can see that it is coming back down in the month of August. I think it will continue to come back down over the next 2 months. The next document in your packet is document number 7, which is per member per month expenses by rate by service category for the Medicaid program. And you know, these are running a little bit higher than they were in the last fiscal year. We did budget more for this year, but we are currently running a little bit higher than what we had budgeted. We think that will come down closer to the budget as we move forward during the year. It is still early in the year, and there is a fair amount of volatility in services from one month to the next. That completes the dashboards and the financial report. The next document in your packet is the budget revision number 3. And I will go through and highlight some of the items in the budget revision. We are moving some funds between, some single stream funds between administration and services. So on about 4 of these lines, there's roughly a $2 million change as we move the funds from services to administration. So I'll highlight those as we go through them. The first item that you see, $1.7 million, is $2 million of that is the reduction related to administration and single stream funds. The next line down at $14 million, that is an increase related to the same $2 million, but it also includes $7.7 million for the state non-UCR EDAC funds. These are allocations that are coming in and will continue to come in during the year. It also contains $2.4 million for the state UCR funds to be drawn down, submitted through tracks for inpatient services for substance use disorders and other detox services. There's about another $850,000 for federal non-UCR funds to support a series of coordinated care networks for veterans. There's another $650,000 for state UCR funds for supporting the clinical start teams. That comprises the bulk of that $14 million. Moving down to the $2.7 million, once again, $2 million of that is the increase relative to the fund balance for administration. But there is an additional almost $800,000 for pension expense, which we are including in the budget now, because we are going to include that monthly in the financial statements so that we can protect as much of our cash relative to this solvency calculation. So it helps us to show more loss and projected loss, which helps us protect cash. So we're moving that pension expense into the monthly financials, and therefore we need to move it into the budget as well. The last item, the $1.7 million, once again, $2 million of that is related to the movement of fund balance for services to administration, and there's another $225,000 that's related to Medicaid and medication-assisted treatment services for the uninsured population. So most of these items, outside of the $2 million movement between services and administration on single stream funds, most of it is related to the allocations coming into the program that we are starting to receive during this fiscal year, as well as the additional $800,000 for pension expense. So, and the last item that the Finance Committee also looked at, the solvency calculations. We've already talked about solvency and the impact that has on us in Brian's report. And we also looked at employee compensation recommendation. This recommendation is we haven't given employees a COLA in more than 2 years. We also, because the state potentially will make us spend down funds related to the solvency calculation, we would rather spend those funds on strategic expenditures that improve our situation, not only with our employees, but with our providers potentially. So we are recommending, or the Finance Committee is recommending that this recognition pay be approved, and it will affect the budget about $550,000 in the current year, and the overall annual effect is about $800,000. It will affect sustainable wages for our employees, some retention for our care coordinators, and some additional payment for our other employees. It will not, any employee making more than $90,000 will not be eligible, or any employee under a disciplinary action will not be eligible, and any employee who's received a salary increase in the past 2 years will not be eligible.
I have a question.
Yes, ma'am.
So when you're talking about any employee that has received a salary increase in the last 2 years, well, some of our employees may have had a promotion or something and more responsibilities. Does this exclude them?
It does. Any other questions? Maybe we come to the finance report.
I apologize if I missed this, but did you guys vote on approving the financial report?
We're getting ready.
Oh, okay, sorry.
We need to do, this is 3 separate motions. The first motion needs to be for the financial reports, approval of financial reports.
So moved.
Okay, we have a motion by Ira. Is there a second?
Second.
Second. Michael, is there any discussion, questions? All in favor of the motion to approve the financial reports, say aye. Aye. Any opposed? Okay, it's unanimous. Okay, approval of the budget revision number 3.
So moved.
Okay, we have a motion. Is there a second?
Second.
Okay. Any questions or discussion? All in favor of the motion, say aye. Aye. Any opposed? Okay, it's unanimous. All right, recognition pay proposal as presented. Is there a motion to approve the recognition pay proposal as presented?
I'll move that.
All right, we have a motion by Dr. Khan. Is there a second?
Second.
All right, we have a second.
Question.
Okay.
As we discussed further, are we actually even needing to approve this, or are we just voicing our support for Vaya and Brian and his team moving forward with this?
I think that's what we're doing, yes.
So we're not really,
You're approving, I think you're approving the recommendation as part of the finance report. It came out of the finance
as
committee.
part of the report. Okay. Good.
Is that what okay. Any other questions or comments about it?
I am real pleased to see that any employee that's making below the certain figure be raised to that figure. I'm really pleased with that.
We have a motion and a second. All in favor of the motion, say aye.
Aye.
Any opposed? All right, it's unanimous. Thank you. All right. Regulatory compliance and quality committee report. Was there, Dr. Khan?
We were one vote shy of a quorum, I thought, but I had voted one of these proxies, so maybe we did. But we can approve the minutes next month. There were 5 areas that we covered. The TCLI monthly report. Some of the criteria that were being judged on for TCLI got changed on the 1st of July. So there's a bit of a moving target. Nonetheless, we are ahead of targets in all areas of TCLI. Core performance measures and compliance. We reviewed the super measures. Remember that super measures, if we don't meet those, they cost us money. And glad to report that we are all in compliance with the super measures and projected to remain above target without problems. We did look at some data with regard to emergency room and hospital utilization. Dr. Heck had a question about why the numbers appeared to be so low when our experience is that that there are a lot of people in emergency rooms and hospitalizations related to substance use disorder. And the reason is that we're only looking at those where the substance use disorder was the primary diagnosis. and it's a secondary diagnosis in a lot of emergency room stuff. So in order to get a better look at what that impact might be, I think Mr. Webb has agreed to research that and get us some numbers for our committee next month. Access to care. Oh, also under core performance and compliance, we did. I think we noted last time that we were fully accredited in 3 areas by URAC. Another review organization, EQR, was on site for the last 2 days before today, and that apparently went well. And then our third accrediting organization is NCQA, and we have selected a vendor to assist in that accreditation, and a contract is in process for that. Where's the access to care? I discussed it. There are minor problem areas with access to care that are being addressed. When we look across the state, we are doing at least as well as our peers in most of these areas. Next area is grievances and complaint report. The grievance committee is going to now be called the resolution committee. On a more optimistic note. In general, our grievance rate has been declining. And that's probably a good thing, since we believe that access to filing grievances is not really being restricted, and this is actually a measure of fewer reports. The appeals quarterly report showed that Medicaid denials are in a stable, low rate now, after a surge that was related to the initiation of resource allocation, which we would have expected to generate increased Medicaid denials. I'll entertain any questions.
Any questions? Thank you, Dr. Brown, for the report. All right, Pat McGinnis, Continuing Family Advisory Committee report.
We held our annual retreat October the 4th and 5th here in Asheville. On Thursday evening, October the 4th, there was a screening of the film Suicide, the Ripple Effect, followed by a discussion of the film. And as sponsors of the community film screenings, CFAC members provided suggestions for ways to make the events feel approachable and supportive for the community members. The film will also be shown in several locations across Vaya's catchment area. The next one will be in Silva on Monday, October the 29th. And I also believe now that one has been scheduled in Rutherford County. Friday morning, Cody Kinsley attended our session to discuss Medicaid transformation and conducted a question and answer session with the members. We were very grateful to have the opportunity to have feedback directly to him. And we also wish to thank Rick French, our board chair, and Christina and Brian for attending, and also to say that we're very appreciative of our CFAC support staff, Ron Shipping and Stacy and her staff. We thought it was a big success, and it was just great getting to spend time with everybody. And we reviewed updates to the member and caregiver handbook and discussed plans to update CFAC bylaws, which some of us are in the process of doing or working with. We have a committee. We will hold our local meetings in early December, and that's still in the planning process, because sometimes in December, because meetings get changed around, I have actually, last year we went to Boone from Lenore, so we're actually trying to decide, do each region want to meet individually or collectively, or maybe a couple of regions meet together and a couple meet separately, so that's in the planning process. Our Vaya CFAC person-centered planning brochure was finalized in printers and printed. Members received copies of the brochures to distribute in the community. 3 CPAC members attended the Provider Summit at the Chris Center, and we feel very fortunate. That was a beautiful, spectacular place. I think you couldn't have picked a finer place to have that, especially in October. I've never heard of it or seen it before, and I just thought it was beautiful. Some of the CPAC members attended, and I'm one, the North Carolina Peer Support Conference yesterday and today, and there were almost 200 consumers there. They were fired up. I think this is going to become an annual thing. It was just fabulous. It was a big success from some of the people I talked to. We had folks come all the way from Wilmington. I tried to do some recruiting for CFAC, and I stood up and talked about it, and I think I've got 2 members interested in Winston-Salem and the Cardinal catchment area, but and some from our areas too. But anyway, I told them about CFAC and different opportunities. So hopefully there'll be some folks calling and filling out applications. Our peer learning community hosted a networking and peer support service definition feedback yesterday evening after the conference day ended, and Ken Schussling came from Raleigh, and we were able to give him feedback directly to him, and other leaders and other people attended and listened, and I thought it was very nice. We had cookies and drinks in that session, and I believe the folks from Raleigh, I feel like they value us here as a CFAC and as a LME, MCO, and the consumers. So I think we had a good day, a good time. And then today was awesome too. Shireen Clarko and some of the other people presented. And the one thing I will say, there's a little bit of tension. I guess might be the right word, and I know I don't have to report on this because I've been reporting on local CFAC, but there seems to be, we've changed chairs of the state CFAC, and so I was on a conference call a week or so ago, and somebody said, well, maybe we need to hold some training so CFAC members could get along a little better and this, that, and the other. And the funny thing was all of us spoke up in defending our relationships and our CFAC at the local level. And so they knew they kind of messed up because the problem's not with the local CFACs. And we all spoke up on this call because it was a state to local CFAC conference call of how much support we all had from, there was one region, and I believe that was the Charlotte region, that did not defend their local CFAC. And other than that, all the regions all across the state were saying, you know, we couldn't ask for better relationships with our LME, MCOs as far as CFACs. We feel valued and appreciated, and so I thought I might just throw that in, let y'all know that, although, you know, there was a letter, I don't know if you got it yet, but somebody at CFAC took on writing that they are hoping, one thing at the state CFAC meeting, they are hoping for more information on data about the TBI clients. And so hopefully that's in the works, but there was quite a discussion about some of that too. But thank y'all, we appreciate all of y'all. Nancy, you have anything you want to add?
The only thing I have to add is sitting around in our retreat, and I don't know why they even think about it, but I was amazed at the amount of knowledge in the room when all the 4 CFACs got together on the areas that they represent, and how much need for IDD, I know it up one side, down the other, MI, I know for my own self, substance abuse, areas that we don't know, we teach each other. And it was amazing to see all of 23 counties coming together in a room and all working together for one purpose. And it was really phenomenal, and having the board support meant a great deal to those people sitting in the room. They
Yeah,
were
we're real fortunate. We have Rick that shows up at CFAC things when we invite him. Not every area has the board chair.
No.
So come to
You guys are
CFAC.
awesome.
Thank you, Pat. Thank you, Nancy, for those there a motion for it? Jeannie's not here, so we'll do the provider advisory council report next month. So, look, is there any other business? Is there a motion to adjourn?
I'll make it.
Okay.
And I'll second it.
Second. All in
This
favor?
has been a long day for me.
Thank you, everyone.
That's-